I think in the past we have treated patients with non-melanoma skin cancers, in particular patients with cutaneous squamous cell carcinoma, with chemotherapy. There were a lot of limitation. This is a particularly old patient cohort, usually well above 70s, with a lot of comorbidities, and many of these patients who usually have been treated with chemotherapy were not eligible to chemotherapy because of the poor performance status, because of the comorbidities they show. What we have learned over the last 2 to 3 years is that because of the UV light, the sun, the mutational burden in many of the skin cancers, and particularly in cutaneous squamous cell carcinomas, is very high, much higher even than in, for example, melanoma, where we know that this is one of the prototypes of developing checkpoint blockade. So over the last 3 years, various skin cancers besides melanoma have been tackled by various new developments in the checkpoint arena. Cemiplimab is one of these antibodies, which now has been approved as a new standard of care in patients with locally advanced and metastatic cutaneous squamous cell carcinoma. And this is based on a global clinical trial which has treated patients after surgery, after failure of radiation, trying to prevent mutilating other treatment options like repetitive surgery and mutilating destructive surgical procedures. And what we have learned is that even old patients, very old patients in the 70s and the 80s, or even above, do tolerate a checkpoint blockade quite well. Treatment discontinuation rates are low, not higher than in younger patient cohorts. It's in the range of 15%. That makes a lot of patients who would not be eligible, for example, to chemotherapy, now eligible to a systemic treatment. That's one aspect. The second aspect, which is of interest, is that the rationale of the high mutational burden and checkpoint blockade, what we know is working also in other tumors, is also working in cutaneous squamous cell carcinomas. We have response rates which are in the range of around 50% in those patients in first-line treatment. We have an excellent disease control rate, which is also long-lasting. We have now follow-up data which have been presented at ASCO and at ESMO this year, demonstrating that this is also a long, durable response. That's another important difference to responses to chemotherapy. Here we know that the responses, if we do achieve responses, are usually short-lasting. So what we see with Cemiplimab, which has been registered 2 years ago now across Europe, this is a very tolerable treatment modality for these patients, a very good treatment option, which provides excellent safety profile and a good clinical efficacy in a lot of patients. And we have treated mostly patients in the clinical trials who had inclusion-exclusion criteria, as it's usual in the clinical trials. But we have learned now in the real-world setting that also patients who have, for example, a certain immunosuppressive phenotype, for example, as part of a underlying hematological malignancy, such as a CLL, are also responding to a certain percentage in that setting, or patients who have received a lot of immunosuppressive therapies in the past, for example, for some autoimmune disease, for rheumatoid arthritis, for inflammatory bowel disease, or whatever. These are all candidates for a higher rate of non-melanoma skin cancers, but they also have a certain chance now to respond to Cemiplimab. I think this is opening the door wide open for these patients to have an effective treatment modality in their hands. And I think for us as a treating physician, this gives us a very new way of treating patients, and I think that's very promising.